Hello, and welcome to this lesson, which is about an example study. And the purpose of this example study, which is a case study that was conducted by Aneja et al., was published in 2018. This example study will show you the diagnostic process by telling you about a case of very early onset schizophrenia. So we'll first start by looking at very early onset schizophrenia and then move on to this specific case. So let's get into it. Very early onset schizophrenia is basically schizophrenia that is found in children or in adolescence, where adolescent is defined as between 13 to 17. Very early onset. Now, onset here means emergence or beginning of the disorder. And so in very early onset schizophrenia, this particular case is about schizophrenia in a male child. And you'll remember from our previous lesson that onset in males is typically around the early 20s, when you see men who have schizophrenia develop full-blown psychosis, meaning that they are in the active stage by then. In childhood cases, diagnosis is quite complicated because a lot of the symptoms are initially quite mild and they can fall into the prodromal stage. And you'll remember this again from our previous lessons about the severity of symptoms becoming worse and worse as the person progresses into the active stage. So as far as males are concerned, usually you see schizophrenia onset in the early 20s, but in this case will show you that you can actually find cases of VEOS or very early onset schizophrenia in children. And this particular case is about a child who's 14 years old, but as you will see, from the age of 10, some psychological disturbance, some symptoms start to make themselves visible and they become worse over time. When you are talking about very early onset schizophrenia, you must remember that for childhood cases or for cases of schizophrenia to be classified as childhood cases, they must be less than 13 years old for the first symptoms of psychosis to emerge. Remember, psychosis meaning symptoms that indicate a disconnect from reality. So do keep that in mind. And it's different. Very early onset schizophrenia is different from adult schizophrenia, such like that which would emerge in the early 20s. It's different because the symptoms are expressed differently. It's also because it's quite rare, and because the sort of treatment and the eventual outcomes are also different for VEOS schizophrenia. So keep these points in mind as we now move into our case history. So this particular case that was published by Dr. Jitendra Aneja in 2018 is about a 14-year-old boy. And there are a few things that you should keep in mind about this boy. He was born into a two-parent household, and it was a normal pregnancy. All of his developmental milestones were met, meaning that in terms of cognition and motor skills, meaning movement and behavior, up until the age of 10, he was developing as he should have. Everything was age appropriate. However, what happens is, what you should also know is that this whole time he had a very aggressive father. There was apparently some history of abuse or violence that the child himself was exposed to. So I think the child was beaten by the father on occasion as well. And all of this is happening before the child turns 10. So what happens when the child turns 10? When the boy turns 10 years old, his parents get divorced because of this incidence of domestic violence, which I think you can trace also back to the father being very aggressive. When the parents get divorced, the boy moved in with his mother, with his grandparents. But by the age of 11, there were some causes for concern, which involved him having many fights at school. There were many complaints. His academic performance really declined. There was decline in his schoolwork. He started to demonstrate sadness. He became quite irritable, and he was then taken to a doctor, a psychiatrist, I believe, who prescribed sodium valproate, which is actually a medication that is used for bipolar disorder. And you'll study bipolar disorder when you talk about when you study mood disorders later on in this course. So he's given this medication of sodium valproate, and his sort of anger issues subside for a little while, and the behavior and the sadness kind of becomes a little better. So you see that this prescription temporarily alleviates his symptoms. Alleviates meaning makes them milder, reduces them. So there's temporary relief from the symptoms. However, again it starts to get worse, and by the age of 12, you see that the boy is now hearing voices. He stops to take care of himself in terms of his hygiene, in terms of his clothing. He starts to have sleep disturbances. He stays up very late, and his family sees him often talking, muttering to himself. He is now on other medications, and he has been hospitalized because of his excessive violence, his outbursts of violence and aggression. By the age of 14, the boy is finally brought to Dr. Jitendra Aneja's clinic. At this point in time, he is termed what is called non-cooperative. Non-cooperative is when a person who has a psychological disorder is brought to a physician, and they are not willing to talk, are not willing to cooperate with, let's say, if a IQ test has to be administered, which Dr. Aneja did try and do to establish more of a baseline. But the boy refused to cooperate. He was extremely aggressive, and his hallucinations had become very, very severe by this time. So this is your entire case history, and these are very important details. You remember from your AS syllabus, case studies are predominantly, they are idiographic, meaning they focus on the individual experience, and they really do tend to capture things that are rare. And you will remember also that VEOS is a rare condition. And so this is the boy's case history over from the age of 10 to the age of 14, before which he did have a very difficult home environment with domestic violence, with violence from his father against him.
Quick pause. If you're finding value in this explanation, there's so much more to discover at Alt Academy, where we break down every A-level concept with the same clarity. Now back to the video lesson.
And by the age of 10, he starts to develop these symptoms. And now let's look at what happened, what these symptoms actually were. So in this boy's case, the positive symptoms, which are the presence of dysfunction, of psychological disturbances. The positive symptoms in the case of the boy at the time at which he was brought to the clinic at the age of 14, he is hearing voices, and this you will recognize as an auditory delusion, auditory hallucination. He is also at this point very suspicious of his mother, and you will recognize this suspicion as a delusion that is persecutory. So he has a persecutory delusion. And you're already seeing now 2 of the core symptoms have emerged. And then he also was muttering to himself. He was laughing and shouting at unseen others. This behavior really exhibits a delusion, which we call a thought echo, possibly a thought echo. Thought echo is when a person who has schizophrenia can hear their own voice out loud, and they start talking to themselves by hearing their voice out loud. So there's an element also here of hallucination, especially when you consider that he's shouting at unseen others. So there's that, there's the, let me just fix this. Yes, there's that hallucination element as well. And these are his positive symptoms. By the time he's at Dr. Aneja's clinic, these symptoms are quite severe. But there are a few other symptoms as well. Negative symptoms, which you will remember, are when there is the absence of normal psychological function. And what had happened to the boy was that he preferred to be alone. He refused to eat dinner or have meals, for instance, with his family. And you will remember this is what we called asociality or social withdrawal. And then you also see that he stops. Then you also hear from, and this information is also coming from his family, by the way, who tells Dr. Aneja that he has also stopped talking. And here you can see clearly there's a presence of alogia. And lastly, there is a lack of self-care. Now, this lack of self-care is actually not necessarily classified as a negative symptom, but it is one of the other symptoms that we had talked about in our very first lesson about schizophrenia. It's one of those other symptoms which is related to behavior, cognition, and mood. You remember that. So again, you see that this lack of self-care does represent a negative symptom in that it is what you call not adaptive behavior. It's not normally functioning behavior. So in that sense, you could consider it as a negative symptom. So these are his core. You can see in this boy, you have three of the core positive symptoms, really, because if you consider the fact that he has this suspicion of his mother and he's hearing voices, perhaps it may not be entirely wrong to assume there may have also been an experience of passivity or lack of control which may lead to the aggression. However, in the case history that we have received, we know that he has auditory hallucinations, persecutory delusions, and potentially also some other sort of delusion and hallucination. Visual hallucination. Maybe he is also seeing other people, and you see these negative symptoms present where he is asocial and he doesn't talk much and he has disorganized behavior or not adaptive behavior. So what did Dr. Aneja do in this case? He had to seek a great amount of clarity in his diagnosis because at the time that the boy was brought to the clinic, he already had seen two different doctors. He had seen two different psychiatrists. He had received by this time a schizophrenia diagnosis, but it wasn't a firm diagnosis. He had also been on multiple medications by the time he came to the clinic. From the sodium valproate, he was then given other combinations of 3 or 4 other drugs as well. And he continued to have these routine hospitalizations because he would have aggressive outbursts. And so really for Dr. Aneja, diagnostic clarification was a long process because he really had to, what he did was that he reduced the medication, which seemed to make things better for a few weeks. But after the boy went home, he once again had to be readmitted because the symptoms came back and they were worse than they were before. And so then he, let's call this step 1, even though step 1 was actually a different kind of assessment, but for our purposes right now, Dr. Aneja reduces the medication, he sees the symptoms again reappear and they are worse, and so he puts the boy on new medication, but then he also prescribes this electroconvulsive therapy, which is also called ECT. You may recognize it in popular culture. It's called shock therapy. So he prescribes shock therapy, and you learn more about this in detail later. So he prescribes shock therapy, And at the same time, he takes the additional steps of having the boy more active in what is called occupational therapy, which is, really involving motor skills and movement. And he gets the boy enrolled in psychotherapy, which is talk therapy. And he also takes this very important step of educating his family better about the condition that the boy has and how to manage it, and how to respond to him when he's very aggressive or when he's extremely delusional or having very strong hallucinations. So this is sort of the process he follows for this very complicated case of very early onset schizophrenia. Putting it all together, why do you need to know this example study? What can you use it for? First of all, it tells you about the diagnostic process and how important a detailed case history for a patient or client can be for a treating clinical psychologist, because the boy's case history is what told Dr. Aneja about the boy's history of abuse, about the troubled family life, about the problems in school, about the aggression that the boy was exhibiting, about the development over time of the core symptoms. If you recall, from age 12 to 14, the hallucinations became quite severe. It also tells you how complex very early onset schizophrenia is compared to adult onset schizophrenia, which is more common. Very early onset schizophrenia is a rare condition. This case shows you how a person can progress from the prodromal stage to the active stage. If you recall, the boy's difficulties really did begin with milder symptoms where, he initially just had trouble at school, he was getting into fights, and then it goes into full-blown psychosis, which is indicated by the hallucinations that he was having by the time he was 14 years old. And lastly, this case demonstrates an extremely important point, and you should keep this in mind as we move through the treatments for schizophrenia as well, that for schizophrenic, for cases of schizophrenia, it's important to use combinations of different treatments. Dr. Aneja used different medications, which are also referred to as biochemical treatments. He also used psychotherapy. He also uses electroconvulsive therapy or ECT, and he uses occupational therapy. So he uses 4 different ways in which taken together, they form the treatment for this young boy. So this is why you should keep this example study, this case study in mind as you move through the rest of the course material.
Hey there! If you found this A-level psychology lesson helpful, why don't you head on over to altacademy.org, where you can sign up for the full A-level psychology course. In addition to psychology, we offered 7 other A-level subjects. Thousands of students have already taken the leap. What are you waiting for? I want to see you there.